America has already written them a check. It's called, these public assistance benefits, but they're not accessing them. And AI can be the bridge to do that and make sure these people actually get what they need. $320 billion a year, the direct costs of folks living in poverty, being sick, and then having to be taken care of in these other ways. Do you know how many charts I got to look at in that 5 minutes, right? How many discharge summaries I got, how many previous ER visits I got to look at, how many primary care doctors' notes, right? And I'm just quickly going through and trying to absorb as much of the information as possible. A large language model could do that way better than I can.
Welcome to AI in Healthcare. My name is Dr. Sanjay, Juneja, also known as the Ankh Doc on news and social media. And today I'm very excited because we're going to talk about AI and how it can help the healthcare system as a whole. And I mean the crazy obnoxiousness that some people experience, not just with health and care insurance rates, but even the cost of things when they have insurance and the reason why, and how, believe it or not, those costs can be reduced with provisions that are already set aside that when adopted reduces the cost for all. We're also going to talk about some of the things that are transforming ER care because my good friend, Dr. Alister Martin, who was a White House fellow, who is at Harvard and has been training there for a long time, and is an ER physician, is going to kind of walk us through everything. The cost savings, how AI can help, what are some of the cooler things we're doing in ERs today, and how truly I think you'll be left encouraged of how healthcare as a whole is just going to quietly improve and rather quickly. With that said, and no further ado, Alister, welcome, and it is so great to have you.
It's so good to be here, Sanjay. It is. We are long overdue for this conversation, and I'm very much looking forward to it. With America's oncologist, baby, the Ankh Doc.
That's it. I saw something pop up on LinkedIn and you were commenting on AI and talking about how it can really be leveraged. And I was like, I feel silly now for asking you, Alister, because Alister got me on a leadership roundtable at the White House previously. That's how we first became friends. And I asked, so you know about AI stuff. And then I immediately felt silly because I'm like, you're the man that knows anything that can be leveraged to help people broadly. That makes you tick. I mean, I know, and dance moves. So I know you can dance too. So there is that. But tell me about that. How did you, I guess, first come to realize what some of the real pain points in today's kind of healthcare system were potentially very amenable or well suited for the kind of technologic, advancement that is AI?
Yeah. Well, first, I want to be honest with you and the listeners, and that is that, my story starts with AI because I'm a lazy piece of shit.
I don't believe that.
And the reality is, I'm always looking for a way to work smarter, right?
Yes.
I'm always looking for a way to maximize productivity. I'm always looking for a way to boost the output of my employees and my staff, right? So I'm hungry for those resources, those opportunities. I'm hungry for those tools. And, at the end of the day, AI is just another one of those tools. And so my AI journey started, with large language model. I'm sure you remember the early GPT-3 days and, asking, ChatGPT to create a poem for you in Swahili and all that. Yeah, you know what I'm talking about.
Haiku.
It was just pure entertainment. But now I would say, I roughly use it 3 times per second. I'm just kidding.
Right?
I use it fairly regularly. And it is one of the most important things that we look out for in our hiring process at A Healthier Democracy. We'll get into what our organization is in a bit, but it is in the lifeblood now of our organization. We signed a big deal with Northeastern Burns Center for Social Change, where they are basically, it's almost like electrifying the grid of our nonprofit of A Healthier Democracy with AI. And so it's a 3-year deal where their AI technologists are really helping us sort of look at every aspect, all of our programs, patient voting, VoteER, Link Health, which we'll talk much more about, and asking the question, how and where can we begin to leverage large language models in each of these different programs?
And, part of the allure is probably that these large language models can really help you get through a plethora of stuff or things like, be it, patient demographics, be it healthcare metrics, be it outcomes that, leave more to be desired and can be more optimized. It's a mess, especially when it comes to nonprofits, and I say when it comes to nonprofits, because somebody is having to do that. And oftentimes, driven by purpose. Yeah. And now you can expedite what generally for nonprofits, people that are doing things outside or in their free time or like employed, but for just such a good purpose, you can expedite all that really fast. It has truly uncovered the identification process. So what are some of those pain points, like, I guess more specifically when it comes to things relating to, your world outside of ER, which is very much this whole ensuring things that exist, which is policy, which is legislation, which are all those things, especially as they relate to healthcare. What are some of those pain points that you are seeing, like, this is what it's doing? Like, this is a problem we've had for a long time, having done this, I'm sure, I think a decade now, probably longer. I'm not sure because you look very young. But what are those things that immediately to you are like, these are the things that were such a pain that we can do now?
Yeah, well, let me get into the work that we're doing at Link Health and how we're using AI to connect patients to over $80 billion in unspent federal and state aid that patients can use to do things like help them, put food in the fridge, to pay their phone bill, to get rental assistance and avoid eviction. The work of Link Health for me really started, I know you mentioned, sort of separating out the ER work from the work that we do at A Health Through Democracy. But it's all intertwined for me, like this work really started in an emergency room. And the idea being that, when folks think of the ER, right, they think of, gunshot wounds, strokes, heart attack,
Calamity.
Right. But the reality, and look, and I'm here for it. I love that. I'm here for it. But the reality is 40 to 50% of the patients that we're seeing in the ER, they don't need to be in the ER. They're there because they have a social emergency. They're there because they have a public policy emergency. Just like the guy I saw 2 nights ago, homeless gentleman, had nowhere else to go, and it was his birthday. So he showed up to the ER, right?
Huh.
And here's the problem with that. That's a $3,000 visit. We did nothing for this man. I gave him a turkey sandwich. I did mix up a little mix. I call it's my mocktail, okay? It's my emergency medicine mocktail. A little bit of Gatorade, a little bit of cranberry juice, and some ice. So so he got
Get out of here.
He got served, but that cost us $3,000, right? So the reality
40 to 50% of these the cases in the ER ish, you're saying, are due to truly a non-medical emergency in the emergency room.
They are due to upstream systemic failures and people being unable, right, to either access what they really need from the healthcare system, or they're there, quite frankly, for an issue that's related to housing, right, or food insecurity, not being able to eat. I had a patient, who I still to this day think about, this young woman who came in 20-something, came in with abdominal pain, and couldn't get a good story out of her. So when you don't, how it is, Sanjay, when you can't really get a lead on the story, you kind of broaden the diagnosis. So we're thinking, this is appendicitis, this is a UTI, etc. She's pregnant. We get her labs back. She has starvation ketosis.
Oh.
She had abdominal pain because she was hungry. I asked this young lady, what's up? What's going on? Like, tell me, shoot it straight with me. And she said, well, my dad's been getting more sick and his medication costs are going up and we've had to make decisions. Do we put food in the fridge? Do I get him his Parkinson's med? Right? So the bottom line is, this is real shit, right? So when I went to the White House and I worked in the Biden White House, the Biden administration, one of the big things that I learned is that every single year there's over $80 billion in funding. That's federal funding, that's state funding, that are these financial assistance programs that people do not take advantage of. And they don't take advantage of them for various reasons. We're going to get into that. But the bottom line is this. The patients that we are seeing in ERs, like our Medicaid population, they live on an average of $21,000 per year. $21,000 per year. That's their annual income. And so these folks are having to make decisions all the time about whether or not their healthcare is more important than some of their other needs. And so Link Health is all about connecting those patients to those financial assistance programs, and we use AI to do it.
That's phenomenal. Am I mistaken, though, to say, is the thinking behind it not to help with their emergency medicine costs, but to actually help support and do the things to keep them out of the emergency room, to where those dollars actually result into a significant potential cost savings, because you just quoted 40 to 50% that are non-emergent situations, but you got to pay the staff, the triage, the time spent, the opportunity cost, the IV, all of this stuff that's being hemorrhaged for issues that there is already money sitting on the shelf to be able to hopefully salvage.
Precisely.
So it's not just a negative, like when it comes to the overall, system in America, it's not this like huge, negative of 80 B, but it's like that, which we'll never be able to, or maybe we can with AI, actually be able to show and substantiate what is actually saved by having a reduction in 40 to 50% of ER.
Let me build on that, because our colleagues at Deloitte just published this incredible report, which nailed it. They published a report on the health wealth gap. The health wealth gap is this idea that folks who are living in poverty, guess what? Not only do they have a much, much, much higher likelihood of getting chronic diseases, of developing cancer in your world, but they also put a tremendous financial strain on the healthcare system.
A disproportionately high.
The story that just told you that the patient is in the ER with abdominal pain because she is hungry. Yes, we gave her food. Yes, we made sure she did not leave without, a list of resources. But did that need to be an ER visit? And look, I'm here for it. We're always going to be open. But I think that there is a better way. I'll tell you one other thing. There's a movement now in medicine that is being termed the money as medicine movement. Money as medicine. Why? Sanjay, you have had the same exact experience I have. You have a patient in front of you. They have a need. And the thing that you and I can do is write them a prescription, when in reality, what we both would want to do is write them a check.
Yeah.
You see what I'm saying?
Yep.
So guess what? America has already written them a check. It's called, these public assistance benefits, but they're not accessing them. And AI can be the bridge to do that and make sure these people actually get what they need. And the studies, to your point, Sanjay, you've immediately intuited it. The studies demonstrate this. Deloitte impact report demonstrates about $320 billion a year is the cost of this, the direct costs of folks living in poverty, being sick, and then having to be taken care of in these other ways.
Well, that's huge. I mean, the two kind of scenarios that I think of kind of immediately are, I forgot what everyone has a different colloquial term for the patients that kind of bounce back or come back to the ER a lot. And one is
frequent
diabetic.
Flyers.
Yeah. What is it? Frequent flyers.
Frequent flyers.
Yeah, some alliterated flay. But, jokes aside, is because basically when the diabetes is so out of control that they're coming in super hyperglycemic and get markedly dehydrated, right?
Yeah.
And you find out it's at the end of the day, that this wouldn't have happened. When I say they're super dehydrated, they need fluids, they need, bicarb to fix their gaps. They often need to be in if their sodium is low enough, but you got to correct it, et cetera, et cetera. All this stuff, sometimes they're in a step down unit or ICU, depending on the facility, could all be prevented by insulin. Like not even tight insulin, but just like, some. But then somebody's like, well, why can't you buy your insulin? And then, we don't think about the fact that you also got to go to the pharmacy, and then how do you get to the pharmacy, and then how do you get, insulin? That's one. And then another one is dialysis. So dialysis is very challenging. You can do it at home, but usually the circumstances have to be really good, which is not the people we're, unfortunately talking about. You have to go somewhere 3 times a week and get all of this toxin stuff removed. And if you can't make it there and don't have it and aren't able to go for those 4 or however many hours it takes, you come in markedly fluid overloaded, opposite problem. The CHF, the heart failure is bad. So now you're giving, hard IV drugs, and then you're really worried about the maybe respiratory issues that are coming from backlogging. All of these things over and over and over again.
Right.
Because they're unable to, for whatever reason, do the stuff that keeps them out. And that's not $3,000 now. We're talking $3,000, you probably mean somebody that comes and goes. We're talking about 100,000 plus.
Absolutely.
Repeatedly. And that's why it's not, quote unquote, I hate the term, like sometimes when it's like a handout or we shouldn't, whatever, it's a cost saving subsidizer,
right.
or like it subsidizes or hedges, even if you want to go that strongly, against something that we already have tons of evidence is a very real thing. Quantitative, research that shows how much is going into this. You just said 300 plus, with a B. I mean, that's 3-4 times what the amount is allocated out there that I assume gets unused. So tell us how AI is helping us identify the people that could be spared of having to return.
So I want to riff for a second. I'm going to answer that, but I want to share some breaking news, because very recently there was a large randomized controlled trial that basically produced evidence to exactly what you said. So your intuition was literally borne out in the data recently. Okay, so this is a big RCT that was just done up here in Massachusetts, just published in JAMA. And what did they do? So what they did was they took patients of a low-income community. It's called Chelsea, which is like right on the north side of Boston, mostly Latino community. And they randomized these patients. And the randomization had 2 arms. One, nothing. Second arm, a little bit of money, like $200 a month. Okay, $200 a month. What happened? 2 big things over the course of just 9 months. 2 things happened. The group that was randomized to the $200 arm, they showed up in the ER much less often. So all those $3,000 visits did happen. And even if they went to the ER, they did not get hospitalized anywhere near as often. And by the way, average hospitalization costs $10K, $10,000, right? So we're not talking bankrolling people here. You know what I mean?
Right.
We're not talking bankrolling. We're talking literally giving people a little bit of breathing room. And what you're going to get on the back end of that is huge cost savings. So let's put the morals. First of all, there's a whole moral argument that we could and should have. But let's focus in on what's the big thing that folks are trying to think about right now. National debt. How do we balance the budget? How do we cut costs? Okay, well, sometimes cutting costs means making smart investments, And so anyway, I think that's really inspiring. And this is just one of several studies in this money as medicine movement that have been published recently. But to your question of how are we using AI, man, I could talk about this all day. But I'm going to be brief, and then you can let me know where you want to go next. So first of all, let's think about this. So there's about $80 billion in these federal funds that are unused every year. The way we look at it at Link Health, we have 2 states that we operate in, Massachusetts and Texas. You might be thinking, why in the hell would you be in such disparate states? But that is the point. The point we're trying to make is we can do this in both. We can do this anywhere. And it's successful. Anywhere. We purposefully were like, let's do it. We're going to Texas. We know what the background is. We know what people are going to say if this works in Massachusetts. So let's talk to the haters before they talk to us. So the bottom line is this. We've identified these 9 different benefit programs. Things like rental assistance, $7,000, a year to just keep you from being evicted. Things like LIHEAP, the Low Income Home Energy Assistance Program. That's $2,000 a year to help defray the costs of your heating, cooling, electricity bills. Things like Lifeline, which is $111. Helps you pay your phone bill, helps you pay your internet bill. Bottom line is 9 programs, right? So let's get into the weeds a little bit. Each of these 9 programs, they all have the same thing. They all have a goddamn application that must be filled out, right? Checked and submit, right? What do you think the questions are? Sanjay, they're all the same. It's name, address, date of birth, phone number, etc., right? So this is a perfect example, perfect opportunity to leverage large language models. Why? Because my navigators, we have about 75 trained certified patient navigators. They can have the one-on-one conversation with the patient. They can build the trust with the patient. They can help that patient get over their fears, or demystify some of these application processes. But my navigator does not want to do 8 different applications at once, right? They don't have the time to have a conversation about Snap and then ask the 20 questions, and then a conversation about LIHEAP and ask those 20 questions, and then a conversation about rental assistance and ask those 20 questions. Wouldn't it be easier if you could just kind of ask the same questions that are used across all of the applications? And that input, that ingested, those answers could then be pushed out to all of the relevant benefit applications you're eligible for, and then the AI can submit them on your behalf, right? So the idea is really, at the end of the day, it's called benefit stacking. If we work with you to fill out your rental assistance application, well, we can, if you qualify, we can apply your answers to the 3 or 4 or sometimes 5 other benefit applications that you also qualify for. And then when we hit submit, it's not just for the rental application. It's for the rental application, it's for Lifeline, it's for Snap, it's for Medicare Savings Program, et cetera, et cetera. That's one concrete example. We've got some others that I could share, but I've been blabbering on for a bit here.
So I need to back up and let everyone understand and appreciate this, because it's something that I didn't think of until this discussion. The link that I'm drawing here it's called link with the word health intentionally in it. And you may say, but you just talked about a bunch of stuff that has nothing to do with medical expenses on the patient. But and correct me if I'm wrong, what I'm piecing together is, because of the data that's shown that, and the statistics you started with on how much is due to means that are unprovided or unable to be, executed in day-to-day life, somehow the hospital system and emergency rooms are taking the burden of a lot of this. Like that needs to be clear to everybody, that the burden is falling on the hospital or emergency room system.
And let me just say one thing to add to that.
Please.
It's falling on you, the taxpayer.
That was my second point.
Oh, okay.
And that was my second point, because what I want to then draw that line to is, please understand that the people that we're talking about, for whatever reason, this is free judgment. I'm at least that way. I know you are, but for whatever reason, they're not the ones that do have the private insurance or everything else. It's because those standards, they're way more frequently have Medicaid, correct? So that's my second assumption. The whole point is Medicaid. Now, let me do a third thing in case people are unaware. Medicaid is a federal thing. You may be hearing this $80 billion and are saying well, there's no more money, Doge, take it out. It's that's a waste of money. But the thing is, if it's federal, but the losses with Medicaid are also federal, and guess what? We're all paying for it. If we're employed and having these statuses, there's loss there. There's loss in the tax dollars. And number 3 is another one that maybe you can't say because I know you're a data-driven guy, but hospitals and the expenses for things are going up and up and up for the people that have private insurance, because it is the only way to stay in the green for a hospital for all the red that it loses. The actual, and I think Mark Cuban said this. I saw a podcast with him saying it. He's like, y'all understand that the loss incurred due to expenses that are unfulfilled fall in the hospital, and they don't have any other way to hedge against that or to make up for it other than try to make it up in other areas, which is why when I went for CT, where I thought I had appendicitis, I've never gone to the ER that often, but I'll say it embarrassingly, they said it was completely negative, which I'm like, impossible. We need AI. But it cost me $2,700. And this was a year out of fellowship. So that hurt. But they go up and up. And there's a lot of post trending where people are well, apparently it's $1,300, or this, if you're uninsured, it's this much, then why is it more if you're insured? Because that's the only way they stay afloat. So this hurts you in multiple ways on your tax dollars and whatever. And that 80 billion, I just need to say it again, it's already been demonstrated on randomized controlled trials, if you believe anything about about research data or science, that goes away to what sounds like not only 1-to-1, but a 2 to 3 to 4 times return on the losses sustained by the federal government. So like, and the federal government is one major entity. And this is why this is such a big and justifiably important topic right now, right? In our climate as of March 2025. So what this is doing is to help the overall costs, in addition to what we're not even talking about, because unfortunately it's not as important, and that's my opinion, that moral and ethical piece of it all. But healthcare is that way too. I've had to learn that the hard way. The healthcare system in general, practicing everything is bottom dollar. And when you accept that, that's when you can make effective change. If you get upset about it, nothing's going to change. You got to play that. You got to learn that game and then start playing chess and with that language. So I think that's an amazing utility of AI. The second thing that I'm thinking out loud, and I don't know if you've had any thought or encounter with this, but there's this whole, I think, a little bit overcorrection on this whole data sharing piece and all of these things. But you could imagine, if I just poof like a genie for a moment, said all of those 40 to 50% of people that were going to the ER and causing these the highest expenses, if in fact they are the ones that could actually not have to come to a large degree due to these programs, imagine what the world would look like. Because now you're still doing it correlative. Okay, least income, Medicaid, and we know that's the trend, so we're going to overlay it this way, because you can't go a layer underneath, because there's some of those individuals that just suffer on their own and don't go to the ER or don't use it for social support. But you're having to go 1 degree of separation away. Imagine if you're able to really identify, and that's a whole other conversation we can have, later or some other time. But that's where I think identification of things and people, especially in the AI era, is so important for cost, for health, for precision therapy, everything. And it's very insulated. Right? We'll never be able to know what those 45% frequent flyers are. And if in fact having these services would actually make that go away, both for them and for our system. So what are some of the things? So this is one granular example of a cost-saving technique. What are some of the things that need to fall into place to continue to really fulfill what you're pursuing, which is a financial argument, because that's the reality, which is really subsidizing your bigger purpose, which is to make sure people get the care, the care they need, but that everyone's happy. What are some of the things that you get excited about, that people can do, or that we can cross our fingers for, to help these kind of things get even more into fruition and hopefully ultimately reduce the cost of healthcare for all of us?
Yeah. So look, I think at the end of the day, we don't sell ourselves or position ourselves as an AI organization, right?
No, yeah.
We are a people first organization. This will always be a people first organization, because that's the nature of the work. Right?
100%.
You have to build the trust. These conversations that we're having with patients about their, quite frankly, financial situations are quite complicated and quite sensitive. And that's the thing I'm most proud, quite frankly, before I move on to answer your question. I'm most proud of our certified patient navigator team, of which we have about 75. They are so warm. They understand how to make a patient feel heard. They validate well. They're very, very well trained in motivational interviewing. So these things, maybe an AI eventually can learn the lingo in a way that will work, but it's going to be really hard to replace that in-person human warmth, right? So it all starts there. I will say that.
And in that capacity, you don't want to replace it,
Right.
But yeah, 100%. I'm glad you said that. But I'm thinking even more broadly within LinkedIn and Link Health, but even as you as Alister, where you because I know the tech. I think the identification process for one is one, because I'm curious how you even identify these people to be able to have them enlisted or considered for this program. Those kind of things, and then also anything else you can conceive outside of that. It's really going to help, I think, just narrow our lens.
Yep.
Or the clarity on where we need to focus.
Yeah. So there are two things that I would say as what sort of we all could do in this moment that we're in, right? The first is directly related to AI, and the second is actually more policy. And I apologize, I'm going to get a little wonky, but I got to be a little specific. You know what I mean? I'm not talking vague terms here. Yeah, the first with regard to AI, bro, if you're not using these tools, yesterday, like I'm sorry, it's too late. Like it's not that AI will replace you necessarily. It's that a human using AI will replace you. And so I think, so that's why I said at the beginning, when it comes to our hiring practices, I'm doing the last round of performance task interviews for a new position we're hiring for. What are we asking people? We're asking people, demonstrate to us how you use AI on a daily basis in a concrete way, professionally, personally, and then show us, walk us through it. Like, you need to be good at AI for us to hire you, right? So what I would say to the listeners out there is, like, take time, learn, try it out on your next project, figure out how you might use some of these large language. And I have no dog in the fight. Use Gemini, use Claude, use OpenAI. One thing I would say to the sort of broader market or economy is, we need more upskilling types of programs to get people quickly brought up to speed on how to use these large language models. Because I think very soon it's going to be, just like our organization, it's going to be a prerequisite for many organizations moving forward. So what I would love to see is the rapid development and proliferation of free courses that have certifications that say, Sanjay Juneja has just gone through the large language model, process in healthcare delivery and is ready to work using large language models. That's a business that somebody's got to create tomorrow, right? On the policy side, so the work that we're doing right now is really only funded through contracts. And it's funding through city and state contracts, right? Because city governments, state governments, they really want their residents on these federal, public assistance programs, right? Because they know it's actually better for them as a city. Think of it sort of from a perspective of a economically savvy, right? Politician who's trying to balance the budget in their own city or their own state. They're saying, well, hold up, we got all this money over here in the federal government, and I got my residents in my city here. Like, yeah, hell yeah, please, let's get them onto this program. So that's basically how we fund our work. But that can't be the sustainable long-term future. So where we are going, I'm very excited to say this, is we are beginning to bill Medicare and Medicaid for these services. Why? Because ultimately, come back to what we said. If you give somebody, look at that research study that I told you about earlier, randomized control trial, $200 a month. If you give people $200 a month, you see ER visits decline, you see hospitalizations decline. And if those are Medicaid patients, you bet your bottom dollar that Medicaid is going to be recouping those costs, right? Those savings. So we've worked out deals. We've signed 2 contracts to begin to bill for these services. So the big policy piece that I would urge, folks listening to this is, keep the pressure on, policymakers to not let those reimbursement pathways go away. Because if you cannot get reimbursed for this work, no one's going to do it, right? So those are the 2 things that I would say, is that on the first, really taking seriously this moment that we're at. It feels a little bit like, I don't know if listeners are surfers, but sometimes when a wave is when you're out there paddling and a wave is coming, you just kind of know, like, I got to start paddling right now. Otherwise, I'm gonna be taken over. Like, this is the moment to start paddling. If you haven't already, to catch this wave. And then on the second, the policy side, we need the reimbursement to be maintained so that this work can continue to be valued in the way that it should be.
Yeah, I mean, as you're speaking, I'm trying to think of 2 or 3 examples that aren't ironically privileged, but the example is simply, if at the end of the day, taxpayers are writing checks for vehicles costs, whether it's to their own healthcare expenses or expenses that are shared, it's literally how you would want to pay for that oil change, and you want to pay for that basic car maintenance, to decrease the number of cars you're having to replace over time. It's like it just makes sense to give that. The other example I thought was like a pool. Like, I had a very again, it's a bad example, but I had a bad experience. I'm going to do it. I'm going to do the pH, whatever. It got messed up. I let it go for a week, and the whole thing had to be drained and replaced and all this stuff. And I was like, this was colossally more expensive than just paying the $100, every 2 weeks. Again, bad privileged example. But my point being is that concept's not foreign to anybody. And it's just connecting those dots, which I'm so glad, we did here.
Well, the cool thing about this for listeners at home to remember and the viewers, the money is already apportioned by Congress. Like, you don't have to pay any more, right? Like,
that's crazy.
The money
that's
is there.
crazy.
Like, we literally just need to connect or link people to it, right?
Aptly named. I love it. This is amazing. We're gonna have obviously, the links so that, because I just, every time I talk to you, you always just drum up this, fire and belly thing that I have to go pursue for the next 6 months, but indefinitely too.
Same here, brother. Right back at you.
Same. Real quick, because we have a few minutes, I also want to know if you know of anything in the ER space that could be improved upon with AI. And I'll give you one example. It was very serendipitous, but I talked to a previous CEO of a major, very successful hospital system here in Louisiana.
Mm-hmm.
And he did some work and realized that one of the biggest holdups on being able to make sure that line, at the end of the year is as green as possible, because of the things we talked about in part, he found that one of the biggest holdups in the ER and keeping it overpacked, and of course, the need for people to have it to see ER and not wait forever, was a disposition by specialists. And a lot of times specialists can be hard for you to hold up, the cardiologist, right? Like, and you're like, yeah, bro, like you don't need to study for that. I know that.
Perfect sense.
You just don't know if they need a bed or not. And then the bed is being held because the ER is saying, I might need it. I'm still waiting on the cardiologist, whether they're there, whether they are not there or there, and just have a whole bunch of people in front of them. So his whole thing was, if we can use...
Literally happened to me 2 nights ago. Like,
what's that?
What you're saying literally happened to me 2 nights ago. So it's like perfectly prescient. Sorry.
And if you think about the downstream implications of that on productivity, efficiency, cost, like revenue generation for the hospital, so we don't have to get these markups on our scans and our labs, I can't imagine how colossal it is. But I don't know if you've ever worn or tried, I'm sure you have, what am I saying, like a Vision Pro, but it's absolutely unbelievable, like the way that you're able to assess and see things in augmented reality. And it's just mind-blowing. I joke, but it kind of is better than real life because there's no obscurity from sun rays and stuff. Point being is he's finding a system to be able to leverage in a telecapacity, but not, it can even be local, on having these headsets to be able to quickly look through the EKG, the echo, some kind of output device, because now that person can do it remotely without the 45-minute commute time, which is that in itself. And you just made the commute times of every specialist you need to call in overnight go away, let alone hire those that are able to get it. You can't imagine just, the downstream cost savings that you would see on the entire system.
So cool.
Both for the hospital, but as a whole. Anything else on the radar? I know there's algorithmic optimizations for triaging. There's just, there's so much that can be done.
Yeah. There's 2 things that come to mind for me. One of which I'm currently trialing. And it is, the first time you experience really good tech, it feels like magic. And that's kind of like where I'm at with this. So I'll start there. I have no conflicts of interest to disclose. I don't get paid at anything, by these companies. But basically the biggest thorn in our side as emergency department clinicians is this idea of having to document. Right?
How did that?
It's a 12-hour shift. I'm seeing 35 patients. I'm literally zigzagging, going back and from a pinball, going between rooms, right? But I got to do this thing for every patient, like write 2 notes, right? I got to write their H&P, the assessment plan note, and then most of them require a procedure, right? So I got to write a procedure note. So, my 12-hour shift turns into a 14-hour shift because I got to sign those charts. I got to, do the notes, etc. So ambient AI has been a game changer for me. I won't say the name of the company because I know there's a couple of really, really impressive orgs out there doing this work. But the one that I have, I literally have my phone with the mic up, and I put the phone in my white coat, so the mic is in my pocket, so the mic is out facing the patient. I say to the patient, just so you know, I'm using an ambient documentation system. It's going to be listening to our conversation. It's going to put that in a note so I can really focus on our conversation. Is that okay? Most of them say no problem. I have the conversation. I forget the phone is even in my pocket. I go back to my computer. The note is pristine. It's fantastic. Of course, I go in, I got to do some stuff to it, but like that is a game changer. So ambient AI is like a very clear place. I feel bad for the scribes, right? Because we have human scribes. We're probably not going to need a lot more of those.
Well, I was just say, like, the problem there, though, is people, what happens is the burden is so big, you cut corners. You end up not documenting stuff, or you forget, or you stack it all together. So there's actually a fracture of historical and ultimately data, which is going to feed our insights one day. That's actually bad data because it's just not possible. So I think there's tangential second and tertiary things like from out of that too.
1000%. And then quite frankly, what's the biggest, I was talking to our CEO of our hospital yesterday. What's the biggest concern in his mind right now? A burned out workforce.
Oh, 1000%.
A demoralized and burned out workforce, not just our hospital, it's every hospital. So if you can do things like this that free up my time, that let me focus on what I want to do, which is actually take care of the patient, wow, that's a big workforce intervention, right? So the second is, a little bit more specific, but you asked, so I'm gonna answer.
Please.
So you're in an ER, and you're the attending physician, and a patient rolls in on the stretcher and is at the double doors of the ER. The double doors open. The charge nurse says, "Yeah, go over there. To room 3. Room 3 is open." So the EMS guys and gals are pushing this patient in the stretcher over to room 3. From the time that I see the patient at the double doors to the time that the patient is moved to room 3 and then transferred from the EMS stretcher to the bed, that's the amount of time I have to review this person's chart. Okay? That is the amount of time that I have to know their past medical history, past surgical history, medications, relevant social history, last visits they had in the ER. And look, you get good at it over time, right? I've been doing this now for what is it now? 10 years now. So I can do it in what does it take? Like 4 minutes, 5 minutes for this whole process? But
That's unreal.
I'm like walking with my computer on wheels, and I'm like, searching what's going on in the patient's history. Do you know how many charts I got to look at in that 5 minutes, right? How many discharge summaries I got, how many previous ER visits I got, look at how many primary care doctors' notes, right? And I'm just quickly going through and trying to absorb as much of the information as possible. A large language model could do that way better than I can.
100%.
A large language could just ingest those notes, right? And just summarize. Say, here, look, here's like the last week of this person's life. Here's the last ER visit they had. And it's one sentence. It's very specific sentences, but they're one sentence summaries. You know what I mean? Because then it's like I caught up. I'm up to speed. But the problem is if we don't do that, if it's up to the human, I might miss something. You know what I mean? And it's very important.
You're going to miss something. Everyone's going to miss something. I mean, it's just a fact. I mean,
and context matters,
especially frequent flyers.
Context matters, so we're dealing in a context where literally seconds are what distinguishes whether or not a patient lives or dies. I kind of need to know, oh shit, this person has HIV. They didn't tell me because they were unconscious. You know what I mean? Like there's a really important, right, piece there, and sometimes not documented in an easy way. So I think that there are these kinds of very, very specific, specialty-specific use cases that you would only really know if you talk to a specialist, when they'd say, oh, yeah, absolutely, here's the thing. And so, somebody, hopefully someone's listening to this or watching this podcast, some really smart entrepreneur is just going to go around each specialty and create a ChatGPT wrapper for all of the needs of that specialist, right?
Already kind of happening. I can't say too much, but it's there are those out there, and you're exactly right. I mean, it's and you can customize what you need to know as an oncologist. I need to know literally smoking history, family history for germline testing. I need to know, I mean, just everything you could think of. When was the last chemo? Did they have recurrence? Blah, blah. For you as an ER, like, I could just immediately think, and it's prompted to where it comes out in seconds.
Right.
How many admissions in the past year? What were the primary diagnoses for reasons for admission? What was the worst metabolic, disturbance in scene? And were there any ICU visits? And if so, what? And also, like, what meds were actually filled in, not on the list, because a lot of times they don't take it. And now you're just reworking everything. They're like, oh, I haven't taken that. I'm like, well, shoot, there goes everything that had to do with metformin that could be, for your renal failure or whatever. Like, to say what was filled in the last 30 days or 60 days, like all of these things, are under works. And I'm so glad you mentioned this one, because the care, again, it's going to be these, secondary and tertiary tangential things that we'll never be able to fully quantify, but just shit's going to get better. Like care is going to get better. The questioning that's peppered 1,000 times that patients hate, including myself as a patient. And I'm like, I just answered this on 3 documents and 2 people since I've been in here. Right. All of that goes away. Right. And it's unbelievable how much somebody's going to be informed when they come in. So there's a lot, and we could, like you said, talk all day about it, but we appreciate you. I personally appreciate you as a friend, as a mentor. I know the country does, in ways that I'm sure are mostly thankless, because I've seen you work very long hours on Capitol Hill, in the ER, and everywhere between. So just thank you, Alister, and we'll send the stuff to be able to support your efforts and learn from you. LinkedIn's a big one, I think, for many people. And if unless there's some parting words, I guess we'll have to do this again.
No, thank you, Sanjay. As I mentioned, you're my idol. So
no way.
If if we can set another one of these up, soon in the future to kind of catch back up, and this is such a quickly moving space that I'm sure the next conversation will be filled with so many more new directions and avenues in AI. So it's been a pleasure. I do want to give a huge shout out to our team at the Burn Center for Social Change at Northeastern, as I mentioned. Really accelerated our AI development and is making things possible that we did not think would be possible at A Healthier Democracy. So the moment is now for capturing the AI energy and the ability to leverage these tools. And so, let's get it done.
Love it. All right, my friend. Be well.
Thanks, bud.